Alison and Julie, if we can get you guys with your cameras on, and we can go straight on to that question. So we had some questions to ask you. I think we just had one question, didn't we, Beth?
Yeah, well, this is quite a long one, isn't it? And probably we thought that everyone would love this one as the last one, because we all hear so many myths and stigmas and stereotypes and stupid things. So we were going to ask you guys what your favourite one is, and can you myth bust it in, what was it, like a minute?
Yeah. So we'll go with who's ready to go first?
I don't mind going first.
Go on then, Julie. What's your myth?
It can change from week to week depending on what's in the Daily Mail, in all fairness, but it's one of the biggest myths, especially with technology at the moment, is that people with type 1 diabetes using Libre or CGM need to achieve a flat line on the tracings, on the downloads, and don't realise actually that that's not what would happen if you didn't have diabetes. You wouldn't get a flat line then, but there seems to be this belief that that's what you're aiming for. So that comes as quite an epiphany to some people sometimes.
Yeah, we said about that earlier. We said Paul Coker, who is One Bloody Drop, bless him, he's got loads of Libre lines, CGM lines and things of people that do not have diabetes. So follow him on Twitter and ask him, and I'm sure he'll happily share them all. But they're ups and downs all the time, and you know, it's not a flat line. So
okay. Alison, what's yours?
So there's a couple of things that again, it's the daily fail probably, but there's the thing I often get asked is, people with diabetes can't eat bananas. You can eat bananas. There's absolutely no evidence to show that bananas do not interfere with diabetes or any medications. And the other thing is the cures. We know that there is unfortunately no cure for type 1 diabetes at the moment, although they are working on it. But then you often hear people saying, not often, but it does get said, you know, things like cinnamon can cure your diabetes. No, afraid not. And more recently, I found out that there was even a myth around cucumber. Cucumber is basically water. How that could help anybody apart from being nice in your cheese sandwich, I don't know. So no, I'm afraid there are a few myths out there, but there's no evidence behind them whatsoever.
Brilliant. So we will leave you to do your talk, Staying Safe in Hospital. So who has the slides? Can you share your screen? And me and Beth will disappear.
Well, Alison and I are sharing this presentation a bit like Phil and Patrick did. So Alison,
point out, Julie, that you're in London. No, I'm in London and you're in Liverpool. So this is across the country presentation.
It is definitely. So I'm going to do the first sort of half, but Alison's in control of the slides. So right, okay, fantastic. So we thought we'd add this in because it's admission to hospital can be extremely stressful when you've got a long-term condition, and diabetes is no different to that. And more so because diabetes, people with diabetes manage their diabetes themselves at home every single day, particularly well, and they will go into hospital and a lot of that independence and management is taken away from them. It can be extremely frustrating. So towards the end of the presentation, Alison's going to talk a little bit about the national move towards improving care in hospital. So I'll let Alison introduce herself. My name's Julie Brake. I'm a diabetes nurse consultant in the Royal Liverpool Hospital, which is quite a big hospital at the moment because we just merged with another local one. Most people have heard of the Royal Liverpool Hospital because it's still being built. Being built for about 5-6 years, and there's been quite a few problems. Alison, do you want to introduce yourself now before we go on?
Yeah, so I'm Alison Cox, and I, up until recently, was the lead DSN at King's College Hospital, which is a very large teaching hospital, a bit like Julie's, in South East London, which presented quite a few challenges, both inpatient and outpatient-wise. I have a lot of experiences with inpatients and with patients using technology. Oh, and I'm now working with Camden Diabetes IPU.
Fabulous. Right. Okay. So what if we go to the first slide? I feel like I'm on the daily briefing now. Next slide, please, Alison. this demonstrates really a lot of the thought processes when people are admitted to hospital, and this sort of word picture here wasn't taken from people with diabetes, but from the Patients Association. So I think everybody with a long-term condition feels a little bit like this when they're going to be admitted to hospital. So the aim of today is to try and alleviate some of your fears, maybe, talk about a bit of planning for maybe routine planned admissions, but also to talk about unplanned admissions, which are more the emergency admissions that potentially you could have. Maybe some tips about what you can do in preparation for being admitted to hospital. And also maybe, and Alison going to talk about this in more detail, an update on the progress that's being made nationally and the national drivers to help improve experiences of people with diabetes whilst in hospital. So on the next slide, we talk a little bit about how the change in routine, if you go into hospital, that everything's different. Your meal times, the type of food you're eating, your medication may be different. Some things might be stopped, some new things might be started. The fact that you're unwell will affect your diabetes. Hypo treatments available, they might not be. You might not have to worry about red or purple jelly beans, because you might have something completely different that you don't like, you're not used to. The blood glucose testing will be different. Some trusts will don't really like you using your own blood glucose meter, which we'll talk about. So there's lots of things that can change. It can feel like it's absolute chaos. You might be in a lot of wards now where you go in. If you're able to, you will be encouraged to manage your own diabetes if you're physically and well enough to do so. But if you are really unwell, then the ward staff will probably take that responsibility away from you just to keep you safe. And as you start to feel better, you can obviously take on board some of that management yourself. If you're on an insulin pump, it's important to remember that if you can't manage your pump yourself at home, not at home, in hospital, it will be disconnected for your own safety and you will be converted onto injections. But once you're well enough, there's no reason why you can't just restart the pump yourself. So it's an idea to make sure you get somebody to bring some of the consumables in for you, especially when you're ready to move over, because the hospital possibly won't have any of those available for you to use. It's also worth thinking about that your insulin doses may be considerably different whilst you're in hospital. So depending why you've been admitted, infections and surgery and any acute illness can really put significant stress on your body, and therefore those counter-regulatory hormones and the stress hormones that we talked about earlier on are rife, and your blood glucose levels are extremely high and you might need a lot more insulin. Or alternatively, the food and the diet and the carbohydrates and everything that you're taking might not be anywhere near as much as you would have at home, and therefore your blood glucose levels might be a lot lower. So it is a stressful period, but hopefully parts of this presentation will ease that anxiety a little bit. Now on the next slide, talking about admissions. So in hospitals we talk about scheduled care and unscheduled care, so planned care and unplanned care. So planned care tends to be anything here that we see here on my right-hand side of my screen. So surgery, so it could be minor surgery, it could be something major, it could be a major operation, it could be hip replacement, it could be abdominal surgery, appendicitis, anything like that at all. Right the way down to sort of a day case investigation, okay, and Phil, I'm not going to try and pronounce the OGDs, but Phil, like scopes and anything like that you might have to fast for and be admitted to a day case unit. And also, let's not forget about someone being having a baby. Obviously, you need to go in and stay at least for 24 hours, if not longer, if you've had a C-section when you have your baby. So what we would say is it's a good idea to speak to your diabetes specialist nurse or your diabetes team, whoever provides your diabetes care prior to your admission. They should be able to really provide a personalised care plan. Now this might be something, especially at the moment, that we do over the telephone rather than face-to-face because of the face-to-face restrictions at the moment. So you should go in with more of a plan of what you think is going to happen and some information that you can take in with you. It might be that your admission is for something quite minor. So again, with the advice from your diabetes team, you might find it has very little impact on your diabetes at all. It's important, obviously, to attend for any of your pre-op investigations if it's for surgery, or any appointments where you can get much more information about what will actually happen whilst you're an inpatient or having those investigations. It's often quite a good idea to take a list of questions that you have, because many times when you go into a clinic appointment or a consultation, that you can go blank and you come out and your family or yourself have said, oh, what did they say about X, Y, and Z? And you think, oh, I forgot to ask. So please take in a list of questions. Nobody really minds. Right, moving on. No, it's fine. It's fine. So unplanned admissions. Okay, unplanned admissions are those sort of emergency admissions. And hopefully nobody really has to go through an emergency admission, but it can happen. And so, for example, this could be from an accident. If you've got diabetes, it could be diabetes related, it could have a severe hypo, hopefully not, or diabetic ketoacidosis. It could be a pneumonia, a sepsis, an asthma attack. It could be any of these. They're all emergency, unplanned admissions to hospital. They normally go through A&E or clinical decisions units or acute medical units, anything like that, and are often via ambulance or the GP will tell you to go straight to hospital. So often this means that you don't have a chance to get something to bring with you, like a go bag or a bag with that you could pack with all your diabetes equipment in, everything you feel you need, with some snacks and some hypo treatments, etc., etc. You might not have the opportunity to do this when it's an unplanned admission. Okay. You might be in quite a lot of pain and you might not be in a position to manage your diabetes yourself, more so in this situation. So on the next slide, something that could happen while you're in hospital, obviously, we'll talk about blood glucose monitoring first. A lot of people with diabetes get quite cross that they're not allowed to use their own blood glucose meters in hospital. It's not always that you're not allowed. It's just that the blood glucose meters we use on the wards are quality control every day. They have external sort of blood-like quality controls done. They feed electronically to the lab system as well, so the diabetes team can look at it remotely. So there's lots of reasons why that they need to use those ward blood glucose meters, as well as possibly you filling in between time if you want to. They might not take the readings off your lever or your own glucose meter as the ones that they use to adjust your treatment. But communication is key, so try and talk to the staff on the ward about what you can use and what they want you to use and what they will use. Now, VRII is something that some of you may well be aware of. It used to be called a sliding scale of insulin. You've possibly heard of this, especially anyone who's been in hospital. And it's now called a variable rate intravenous insulin infusion. So you'll have to, this is normally if you're not well, if you're not eating and drinking, or if you're in a DKA or you're quite poorly, you'll have two separate infusions, an insulin infusion and a dextrose infusion. Now, people who have very high glucose levels in hospital with diabetes often get quite concerned and anxious that they're being given dextrose infusion whilst their blood glucose levels are very high, but actually it's part of the treatment, and it really is safe because of the insulin that you're having alongside. So you will get a dextrose infusion and an insulin infusion at the same time. Okay. So if you're not in DKA and you have a VRII running, they will usually or should usually administer your long-acting insulin alongside this. So don't be surprised if that happens. And then once you're able to eat or drink again, there should be an overlap period. So you should probably have the VRII running for about half an hour after you've had your first dose of insulin. Okay, so don't be surprised if that overlap is happening as well, because that's quite right. So on the next slide, and talking about being prepared. I talked about a go bag just now, didn't I? And if you're coming into hospital, it can give you a little bit more confidence if you know you've got things that you're used to with you. So hypo treatments and some snacks and things like that. It's quite important that you take those with you. Contact your diabetes team. If your diabetes team is based within the hospital you're being admitted to, then that's usually a bonus, and you can ask if they can come and see you whilst you're in. If they're not based in the same hospital, or the hospital you're in doesn't have a diabetes team, your team could probably liaise with the people who are looking after you to try and advise on the best management of your care, or some history around your diabetes. Okay. So on my last slide now, I think this is Diabetes UK. It might not be my last slide. Diabetes UK did quite a lot of work about self-management in hospital, because this is, as I said, one of the things that people with diabetes get quite concerned about, that everything is taken away from them. They feel they've got lack of control, lack of self-management. And the two things that did come out from this talk and exercise that Diabetes UK did with lots of people with diabetes was about food and diet, but then also about self-management of their condition. And although this piece of work only goes back a couple of years, self-management has been pushed in hospital for at least a decade now. And on the next slide, we can see the ABCD guidelines go back to 2012, and ABCD is a national Association of British Clinical Diabetologists, and they produce guidelines for hospitals and diabetes team, and are quite high profile really with diabetes management in hospitals. And they brought some recommendations in with regards to self-management. So really what hospitals should be doing is providing written information to you as a person with diabetes around self-management, coming up with some agreement between yourselves and what they feel you are able to do and what you feel you can do. And often there'll be a signed sort of agreement form on insulin administration or medication administration on the wards and self-testing. So it demonstrates that this is a serious thing that is being taken nationally now, and really we're hoping in our organisation we have self-management on the wards, and you know that sometimes it's difficult because of other people that are in that clinical area or that ward as well. So there's lots of caveats there that will be discussed with you. Okay, so I'm going to sort of hand on, so it's a bit of a whistle-stop tour there. I'm going to hand over to Alison now to carry on with the presentation. Thanks, Alison.
Okay, thank you, Julie. So yes, so that was what you can do and some of the things that might affect you while you're in hospital. Just to run through, and I'm aware I've got the real graveyard shift here. I'm the last speaker of the last talk, so I will keep this as brief but hopefully informative as possible. So what we do know is that we have made improvements. We know this because the teams in England, hospitals in England and some in Wales and in Northern Ireland, do a thing each year called the National Diabetes Inpatient Audit. This is where we go around and we literally audit every single patient that is an inpatient that day. It's always done in September. And we know from 2011 to 2017, we were able to do things like reduce medication errors, reduce episodes of hypoglycemia, including those that were very serious, where somebody needed an injection to help them with a glucagon. And we know that we've increased the number of patients that are seen whilst they're in an inpatient. And not everybody is needed to be seen, but of the ones that should have been seen, we've gone from 58% to 72%. Obviously still room for improvement, but we are getting there. And it's just to show you that's one of the regulatory bodies that we do have in the NHS that keep an eye on us, and how actually we as diabetes teams can sort of self-regulate ourselves as well. So in 2018, DUK, along with Jerry Raymond and Emily Watts from DUK, came up with this document. This was very useful to us because it helped lay down more ground rules, and it gave us evidence and information that we could use when we were going to our commissioners or hospital management teams with our business cases, so that we could get more inpatient nurses, get more pharmacists involved, get more dietitians involved, and something that we've talked about a lot today, more psychological help for patients with diabetes. Why was it important? Some of the reasons I've just said, but as you can see, it was setting up staffing levels. We had recommendations about how many nurses we should have, including those ones to run a 7-day service. Something that a lot of people say, they can get hold of somebody sort of 9 to 5, but they get admitted 2 o'clock in the morning on a Sunday. It's nice to know perhaps that the diabetes nurse will be around during the day to help them. It also gave us more evidence toward using electronic prescribing, which I will come to, but electronic prescribing has been very helpful in reducing some of the medication errors that we were seeing and prescribing errors. Linking blood glucose and ketone meters into hospital computer systems, that's very important, because that enables your diabetes team to have a real-time report of what's going on, and then we can be proactive. We can pick out patients who need to be seen, who perhaps haven't been referred, and get to them more quickly. We also have things a little bit grim, the titles, but these are basically meetings where we look at what's been going on and see where we can learn, what points we can learn from, and what improvements we can make. And training. I'm going to come to another slide, but training is so important, not only for us, but for the non-specialist teams that we have in the hospital, or non-diabetes specialist teams, I should say. So what does this look like at a local level? Well, I've already sort of hinted at this, but training for all hospital staff is vital. As Julie said, we've been doing this for years, but again, in 2018, we had this push that really helped with it. So we do study days, we do short teaching sessions. Some people call it guerrilla teaching. You sort of go to an area where you know there's a problem and you tackle that specific problem, whether it be hypoglycemic treatment or problems around the variable rate insulin infusions. Some hospitals are lucky to have simulation suites, so you can actually have computer-generated dummies that will look like they're having a hypo or a DKA. And again, this is really useful. We have nationally recognised and validated training schemes. One of them is the 10-point training scheme, which was set up by Ruth Miller and her team. And then we've got increasing use of web-based courses. Now, it sounds simple to us now. We especially in lockdown, we've all gone to the web. We've all gone looking at electronic things. We're using things like this video conferencing now that we weren't doing this time last year at all. But using web-based courses and validated ones mean that staff can study in times that suit them, rather than having to go on specific study days, which are obviously sometimes quite tricky. The early identification I hinted at, that again was down to improved use of electronic systems and improving early referral by ward staff and picking up these early warning systems where we pick up patients. We've also got safety features, many safety features. Again, that's the reflection, learning from the adverse incidents that we call them. So when things do go wrong, we don't just sort of bury our heads in the sand. We try and we look at it, we try and learn from it. A bit like any industry, really. We know engineering uses this. The airline industries, I believe, were quite foremost at sort of bringing in these sorts of systems. We have safety alerts, and we use the safety warning alerts for electronic prescribing. One of the national ones was in the Insulin Safety Week and Hypo Awareness Week, and also Diabetes Awareness Week. Insulin Safety Week, we all probably went to bed saying this in our sleep: right person, right insulin, right dose, right device, right way, right time. That was a very easy mantra to get into ward staff, so that insulin was given in a timely and correct manner. Ongoing, I mentioned at the beginning, the NaDia, which is the National Diabetes Inpatient Audit. There are many diabetes audits. There's a National Diabetes Audit. There's one about pregnancy. There's one about pumps. There's quite a few. So again, as I said, that was you're looking at all the diabetes inpatients. And in that, started with a pilot back in 2009 and has run nearly every year, but not quite up until last year. The 2018 audit was just looking at hospitals, and that's what captured staffing levels, and we were able to show improvements there. Unfortunately, because of COVID, we should have had the 2019 results this year at Diabetes UK, but you all know why that didn't happen. There's a further audit as well called NaDia Harms, which is an ongoing collection, and that looks at 3 specific areas: hyperglycemia, DKA, HHS, which is hyperglycemic hyperosmolar state, and which is sort of the type 2 equivalent of a DKA, and the formation of diabetic foot ulcer in hospitals. As you can see, we are still having some, and again, we're looking at ways around and how we can improve that. So the NaDia 2018, one of the key things for me was we were able to improve the hours per week that we had a DSN to see inpatients. We have increasing use of the electronic systems, electronic prescribing, but still some work to do because over half the sites don't have it. And at least 1/5 still didn't have any DSNs on the wards, or diabetes inpatient specialist nurses. I suspect that has improved greatly because we've had funding for 20 areas to have additional inpatient teams. We've got the Joint British Diabetes Society behind us and National NHS England transformation funds. We also have the Getting It Right First Time, the GIRF report. This was when we had to reflect back on our teams. We were asked to answer certain questions about it. This data was analysed, and then we were given a kind of how are you doing, a kind of school report. This went out to all the teams in England, and we were able to reflect and see which areas we needed to focus on to improve. From my personal side, we had to improve on our self-management programs, which we were able to do. So you can see there's a lot of work going on. There's a lot of governance going on. We're aware that it's not perfect, but we are definitely taking the right steps and going in the right direction. So in summary, I just think being prepared for your admission as much as you can, can't always, but if you are going in for an elective procedure, try and have that go bag ready, try and talk to your team or the local team, find out as much as you can about what procedure you're going in for. And if you're at all concerned, do talk to your team because they can give you a care plan to take with you. I've done it many times with patients who are going into hospitals that aren't our local hospital, giving them a care plan, or at least explaining background of their diabetes and any kind of specific things that they felt needed addressing. The improvement programs and initiatives are happening nationally and locally and are ongoing, and we continue to strive to make your inpatient stay better as much as we can. Okay, I'm sure there are some questions, so I will unshare my screen, I think, and hand back to Beth and Amanda.
Julie's still there as well.
Hope so. Yes,
she is. So there are a couple of questions that are probably more paediatric diabetes based. So we did ask Sam, whilst you were talking, we asked Sam to give us the answers to these questions.
Okay.
So the first one was, if my child got admitted during this time, would I be allowed to be with her? I think it's because of the whole COVID situation.
I couldn't hear the question.
It was basically if a child is going in for surgery and they're type 1 and it's usually be a day case, would it be more likely that they have an extended stay, or would it still be a day case procedure?
So certainly what we do with the adults is we try and get them on the list, first on the list, so that they would go in first. So hopefully you can get it all done on the day. You can never sort of predict what might happen, and so they might decide to keep them in overnight, but you would hope that it could be done on the day. But I would certainly expect to be in the hospital the whole day, up until 6 o'clock at night. Yeah.
Cool. Okay. And well, the other question more generally for like adults, wasn't it, is people just generally worried about equipment being taken away from them, meters, anything, if people are looping, that kind of stuff. So
this is where the self-management guidelines come in. I was actually on the team that wrote it back in 2012, and the idea, the whole ethos behind it was that if you were able to, you could look after your diabetes yourself. Obviously, back in 2012, we didn't have quite as many using loop systems or DIY or open APS, etc. I think the problem will be when you're coming in is that you need to make sure that the team looking after you, so whether that be an orthopedic team or a gastro team, understand that you do know what you're doing. So I know that sounds a bit odd, but again, that's where liaising with your diabetes team can come in, because we can then speak to them or provide information, because they won't have seen your equipment. People haven't even seen insulin pumps, because the numbers in the grand scheme of things, if you imagine the millions of people we look after in the NHS, this is a small proportion of it. So they don't know about it, but we do encourage people to be allowed to look after their diabetes as much as they're able.
Yeah, cool. Thank you so much.
And you shouldn't have your meter taken away from you. You shouldn't have your pens taken away from you. They can be stored next to you. You should have access to your hypo treatment. You should be allowed to use your hypo treatment if it's your choice. If you don't want to use the glucose juice, we can explain that your 4 jelly babies are the same amount of carbohydrate, that sort of thing. Often it's just maintaining those lines of communication between the diabetes specialists and the ward staff or other specialist teams.